A common complaint among clinicians is that landmark-based ankle blocks don't work. Some even argue that neuropathic patients won't benefit from them at all. But the problem isn't the block, it's the technique. Landmark-based approaches are inherently inconsistent because you're injecting blindly and hoping for the right spread. Ultrasound changes that entirely. With ultrasound guidance, you can actually see the nerves, identify anatomical variations, and confirm spread around each target. What might be dismissed as ankle blocks don't work is often a limitation of the landmark-based technique, not the block itself. So with that in mind, let's get into it and break down how to perform reliable, reproducible, ultrasound-guided ankle blocks. Innervation of the foot is supplied by the tibial, saphenous, deep peroneal, superficial peroneal, and sural nerves. The tibial nerve is easily identifiable behind the medial malleolus just posterior to the posterior tibial artery. The tendon of flexor digitorum longus is seen just anterior to the posterior tibial artery. Sliding proximal allows the needle trajectory that will avoid this tendon. An injection of about 5 mL of local anesthetic here will provide analgesia to the plantar surface of the foot. We've increased the ultrasound depth in this example to visualize spread around the nerve as it's pushed down with local anesthetic. The deep peroneal nerve and dorsalis pedis artery lie together on the dorsum of the foot between the extensor hallucis longus and extensor digitorum longus tendons. As we scan distally, the nerve rolls to the lateral side of the artery. An injection of about 3 mL of local anesthetic here will provide analgesia to the web space between the first and second toes. To identify the superficial peroneal nerve, place the ultrasound on the fibula just above the lateral malleolus. The posterior bicycle helmet-shaped muscle is peroneus brevis, and the more square-shaped anterior muscle is extensor digitorum longus. As we move proximal along the fibula, the muscles come together to form a V-shaped groove. In this groove, we can identify the superficial peroneal nerve. About 3 mL of local anesthetic here will provide analgesia to the dorsal surface of the foot, with the exception of the first web space, which is supplied by the deep peroneal nerve. In this example, as we scan distally post-block, we see the superficial peroneal nerve well surrounded with local anesthetic. The sural nerve can be found next to the small saphenous vein in a saddle-shaped fascial plane between peroneus brevis and the Achilles tendon. As we move proximal, we see the vein and nerve hook over the Achilles tendon. Surrounding the sural nerve with about 3 mL of local anesthetic will provide analgesia to the lateral surface of the foot. The saphenous nerve travels alongside the saphenous vein just above the medial malleolus. It's very tiny and you may not see it on ultrasound, but as long as you can identify the saphenous vein, a perivenous injection will cover the saphenous nerve. An injection of about 3 mL of local anesthetic here will provide analgesia to the medial surface of the foot. The landmark-based approach to the ankle block relies on assumed anatomy and unpredictable spread. In this example, a ring of local anesthetic is made between the medial and lateral malleoli to block the saphenous, superficial peroneal, and sural nerves. With ultrasound guidance, we visualize each of these nerves and confirm targeted local anesthetic delivery. When we stop guessing and start seeing, ankle blocks stop failing and start working.